Hi all. Today we are going to discuss about mesentric circulation, a very important exam topic. So mesentric circulation with respect to the foregut, celiac trunk arising at the level of T12, branches, left gastric artery, hepatic artery and gastroduodenal artery. Midgut is supplied by supramesentric artery arising at the level of L1 vertebra. Branches, ileocolic artery, right colic, middle colic artery, jejunal and ileal branches. Hindgut, inferior mesenteric artery arising at the level of L2 or L3. Branches, left colic artery, sigmoidal and superior rectal artery. So how do they having the collaterals? So foregut and midgut is mainly formed by collaterals. Superior pancreatico-duodenal artery, which is arising from celiac trunk. Inferior pancreatico-duodenal artery arising from superior mesenteric artery. Arc of Riolan, which is connecting superior mesenteric artery and inferior mesenteric artery. Marginal artery of Drummond and unnamed vessels. Inferior mesenteric artery to the rectum is mainly by the hypogastric plexus, hemorrhoidal plexus, and also the branch from internal iliac artery, which is connected by the middle rectal artery and inferior rectal artery. So what pathophysiology happens? Decreased mesenteric arterial blood supply will lead to ischemia. So thereby postprandial abdominal pain occurs, and this is very important. Symptoms are out of proportion to signs. So if there is increase in metabolic demands after eating, that is postprandial, there is a decrease in the mucosal blood supply, which will lead to lactic acidosis, hyperkalemia, and full thickness necrosis will cause metabolic acidosis. So as we know, anaerobic metabolism, lactic acidosis occurs, sepsis sets in, increase in WBC count, fever response, and full thickness necrosis mainly cause perforation. So what are all the type of mesenteric ischemia? Acute, chronic, NOMI. NOMI is nothing but non-occlusive mesenteric ischemia. I will tell you what. So acute mesenteric ischemia is divided into embolic and thrombotic phenomena. Chronic mesenteric ischemia, involvement of collaterals. In acute mesenteric ischemia, what are all the signs? In early phase, there will be abdominal cramps. In late phase, there will be fever, guarding, rigidity, and there will be nausea and vomiting occurs. Embolic phenomena, predominantly the cause is due to rheumatic heart disease, atrial fibrillation, or even CVA associated presence, cerebrovascular accident. So most common site, SMA, middle colic vessels involvement. Thrombotic origin at the level of SMA. The pre-existing atherosclerosis is the most common cause. Okay. So what is the investigation of choice? Arteriogram. So what is the sign present? Meniscus sign, distal cutoff sign is present. So treatment, 100% O2, warm compresses. For embolic phenomena, we need to perform a open procedure, clamp at the level of origin of SMA, transverse arteriotomy, removal of clot using Fogarty's catheter, then close arteriotomy site and restore the blood flow, reassess the bowel viability. Thrombotic phenomena, do bypass grafting. It is of two techniques, autologous and prosthetic. Autologous technique involves saphenous vein grafting. Prosthetic technique is contraindicated in case of ischemia. Prosthetic involves Dacron graft, PTFE graft. What are all the endovascular procedures? Catheter directed thrombolysis. Thrombolysis with urokinase or recombinant TPA. No acute abdomen within 12 hours of onset. And this is a very important, do the emergency surgery. It's an indication. How to differentiate a viable and non-viable bowel? Viable bowel is shiny, firm, with peristalsis actively present. Dark color becomes light, which is pink, and visible pulsation in the mesenteric arteries. Non-viable bowel is dull and lusterless, flabby, no peristalsis, dark color, that is the congestion remains, and no detectable mesenteric arterial pulsation. Chronic mesenteric ischemia, which is pre-existing atherosclerosis, which leads to progressive luminal narrowing because of extensive existing atherosclerosis. Pain increases when there is obliteration of collaterals. Postprandial abdominal pain, its insidious onset. Fear of food and vomiting occurs. Fear of food is a classical symptom and postprandial abdominal pain of mesenteric ischemia. Symptoms occurs when there is occlusion of more than or equal to 2 out of 3 vessels. Arteriogram, which helps to show the collaterals. Treatment: revascularization procedure, elective surgery. We need to perform open procedures, transaortic endarterectomy and bypass grafting. Endovascular procedures can be done prophylactically in patients with endovascular aortic surgeries. So, what is transaortic endarterectomy? It is done for osteal lesions with distal patent coronary celiac artery and supramesenteric artery. Bypass grafting with sulfonylurea is an autologous grafting, or you can go with a prosthetic grafting. In case of endovascular procedures, can be done also for recurrent anastomotic stenosis. We can also perform bypass grafting with autologous and prosthetic grafting. So the point here is, if there is an SMA thrombosis, look for viability of the bowel. Look for pathology. So the point is, if the pathology is embolic or thrombotic, design the plan of management. So we are going to perform emergency surgery and elective surgery. So in case of an emergency surgery, open or endovascular. So if it is an embolic disease, do embolectomy, remove the embolus, and then by using trans-arterial forgettes removal. If it is a thrombotic occlusion, now perform either two techniques: autologous bypass grafting with GSV, or prosthetic grafting with a very important prosthetic grafts with PTFE or even Tancron graft. So what is non-occlusive mesenteric ischemia? So it occurs in patients with shock on vasopressors like norepinephrine. No intraluminal occlusion. This is the key. It is only a vasospasm. So we did CT arteriogram, which mainly shows vasospasm. Treatment: catheter directed direct injection of vasodilators using phosphodiesterase inhibitor, tolozolin and papaverine. So what are all other causes? There is one thing called median arcuate ligament syndrome. Celiac trunk is compressed by the median arcuate ligament. So median arcuate ligament is over the aorta, which is the normal anatomy, and over the celiac trunk. There is an angulation which is around 90 degree, and the weight is compressing over the celiac trunk. Evaluate this condition before performing endovascular. Do median arcuate ligament decompression either by performing laparoscopic ligament release. If there is persistent stricture is present, perform bypass grafting technique. In case of an aortic surgeries, ischemic colitis can occur. And what are all the other types? Like radiation arteritis, mesenteric arteritis, and cholesterol embolism. Do echo scan. Look for LV thrombus or any mitral valve thrombus in case of rheumatic heart disease. CT will show pneumatosis intestinalis, gas in bowel wall, gas in the portal vein. Thank you. Subscribe at Inspired Surgeon. Share to your friends and colleagues. Thank you.